I'm an educational consultant with Advanced Nurses at ACD for N, and I have the pleasure of being here with the coding nurse. We are going to do an inpatient CDI record review and a demo of his course. So a part of this presentation is going to actually include you getting an idea of what his course looks like. I'm really excited about this opportunity because one of the things that I'm learning more and more, and this is something that the coding nurse and I both agree on, is that clinical documentation integrity really is about capturing the most accurate picture of the client, documenting high quality care. It influences reimbursement, and there's so much other factors within healthcare, revenue and everything that is impacted by provider documentation. And so I really believe, and like I said, the coding nurse and I both strongly believe that nurse practitioners, we really believe that nurse practitioners could actually have a huge advantage if they master clinical documentation. So this is not just a presentation for nurses that we want to learn about clinical documentation integrity and learn about ICD-10 coding and learn how to do medical record reviews to pull this very important information for CDI. But we also want to encourage providers to take this as an opportunity to really be true owners of their documentation and really lead the way. We strongly believe that nurse practitioners could have a huge advantage in this area by having the most highest quality documentation. So I don't want to hold up your time too much, Coda Nurse. I'm going to turn it back over to you.
All right, thank you, Raquel. So what I'm going to walk through is an example that is going to combine coding as well as CDI, and you'll see why, as a nurse or a nurse practitioner, it is really important to understand coding guidelines, because the coding guidelines combined with the clinical piece and the clinical aspect of nursing that a nurse would bring to, or a nurse practitioner would bring to CDI, makes you a lot more effective in your role of CDI. Because in order, in my opinion, to really be effective in CDI, you have to master coding and the coding guidelines, because CDI and coding work hand in hand. Normally, CDI will follow the patient from admission through the discharge, and then once the person is discharged, then coding takes over the case. So we get to see, as a CDI, we get to see the case and follow it through. So we are the first ones. We're the first set of eyes on this medical record. So we should be capturing everything. So all coding has to do on the back end is just code what we have found, because by that point we should have cleared up any kind of unclear or ambiguous documentation. So we're going to go through an example, and this example is the causal effect relationship between hypertension and heart failure. So the objectives are for you to learn proper code assignment for hypertension and heart disease / heart failure, and for you to learn to utilize coding conventions and guidelines to assist in proper code and DRG assignments. So with hypertension, plain hypertension, so hypertension without any associated conditions is coded as I-10. Hypertension has an assumed causal relationship with heart disease, heart failure, and chronic kidney disease. If any of the above conditions are documented along with hypertension, you cannot use the hypertension code I-10, because there is a combination code category that you have to use based on the coding guidelines. So hypertension with heart disease, and these two bullets come directly from the coding guidelines. Hypertension with heart conditions classified to I-50.- or I-51.4 through I-51.7, I-51.89, and I-51.9 are assigned to a code from category I-11, hypertensive heart disease. This is used additional code or codes from category I-50, heart failure, to identify the type or types of heart failure in those patients with heart failure. The same conditions, I-50.- through I-51.4 through I-51.7 I-51.89, I-51.9 with hypertension are coded separately if the provider has documented they are unrelated to hypertension. Then you would sequence according to the circumstances of the admission/encounter. So I put together a little graphic to kind of show you what elements you would need to use code category I-11. So you have to have hypertension, and you have to have either heart disease, which is going to be your I-51 dot dash, and the first three characters before the decimal point in medical coding is called a code category. So you have to have a code from code category I-51 and or a code from category I-50, which is heart failure, in order to use the code I-11. And once again, this would be based off an assumed relationship, meaning that the hypertension is causing the heart disease or the heart failure. So now we're going to switch to the PDF, and we're going to review a discharge summary before we proceed with the rest of the lesson. So our discharge that we see here is an inpatient discharge summary. Our patient is Jane Doe. This is her date of birth, her sex, date of admission is September 2nd, and date of discharge is September 4th, and the attending is James Bond. So her discharge diagnoses are chronic systolic congestive heart failure, diabetes mellitus with neuropathy, which is documented as stable, hyperlipidemia, and hypertension. So for her hospital course, it says 67-year-old female who was admitted on September 2nd with complaints of shortness of breath and chest pain. She was found to have fluid overload secondary to chronic systolic congestive heart failure. Her cardiac workup was negative. On admission, she was diuresed with IV Lasix 40 milligrams and continued daily with relief of symptoms and improved chest x-ray results. Daily weights and strict I&O supported improvement secondary to diuresis. Home dosage of PO Lasix increased the discharge. Follow-up with PCP encouraged. Blood sugar remained within normal limits during admission on home dosage of Novolin 70/30 for diabetes mellitus with neuropathy. In summary, Jane came in with severe dyspnea and chest pain secondary to worsening CHF. Her discharge was rather delayed due to insurance issues. Medical assistance was obtained for her, but Jane refused to go to a skilled nursing facility for inpatient rehab. She is competent to make this decision, and she had decided to go home. So we helped set her up with in-home PT, physical therapy, and home health services. So these are her medications, and these were the diagnostic procedures that were performed in-house. So she had one 2-view chest x-ray which showed bilateral pleural effusion, and she had a repeat, the chest x-ray number 2 views which showed no active pulmonary disease noted. She also had a CT of the chest, and the findings were left pleural effusions. She also had an echocardiogram which showed left ventricular hypertrophy. She had an ejection fraction of 45%, and no pulmonary hypertension was noted. Her discharge disposition was home with home health services, and the note was electronically signed by James Bond, MD. So we see now if this were to go to coding, before CDI took another look at it, they would probably just code the chronic systolic heart failure. But this is where the clinical piece comes in, because we see that we have clinical evidence to support a more acute instance of systolic congestive heart failure. And the clinical indicators, which we're going to talk about later on, but I want to point them out here and then we'll review again, is the person was treated with IV Lasix 40 milligrams. They weighed her daily, so she had daily weights and strict I&O. And it also is documented that all of those modalities improved her her symptoms secondary to her releasing all this fluid from the IV Lasix. And this also supports the IV Lasix also supports her medical necessity for her being in the hospital, because you have to be in the hospital to have IV Lasix and to have strict INOs monitored. So we see that this IV Lasix is going to be key to her. And she also, her admitted diagnosis was fluid overload. But we're going to get into that once we delve into the coding guidelines and coding clinics around heart failure later on. But I just wanted us to take a look at the discharge summary to see what was going on and what her hospital course was. So now we're going to go back to our presentation. And these are the codes so far. We have hypertension, we have left ventricular hypertrophy, we have hyperlipidemia, we have diabetes with neuropathy, and we also have heart failure. And we have chronic. Then we also I'm gonna show you why we looked up acute on chronic, because when we go back to our discharge summary, we see evidence that this would be because heart failure is always coded and described by type and acuity. And we already have the type of heart failure. She has systolic heart failure, which is also evidenced on her echocardiogram, where she has the ejection fraction of 45%. So anything below 55%, 50 to 55% is typically indicative of systolic heart failure. And then we also code heart failure by type. So the discharge summary has chronic, but we have evidence that there could be an acute exacerbation. So that would be acute on chronic. So now when we go to our coding book, and we see this is the 2024, and actually tomorrow is the last day for this edition of this code book. The 2025 book starts on October 1st, which is Tuesday. So how you find these codes is you go to the main term in the alphabetic index, and then from the main term, you go under the main term into the subterms to find the more descriptive codes. So we're going to go to failure. We're going to go to failure, and then we're going to go to heart. So you always go to where the first entry starts. So these are our main terms: failure, failed. Then we're going to come down on the first gray line, because you work from the outside in. We come down to the first line, which is heart. So now we have heart failure. So now under heart failure, you don't go to this line. You have to work step by step. So we have to go between the two gray lines. So we know that this person has systolic heart failure. So between the two gray lines, we have to come down to find systolic, which is right here. Then from systolic, we work in and we have chronic, because she's diagnosed, the discharge summary states chronic systolic heart failure. So that gives us I-50. I'm sorry, we come down to chronic, which is right here, under systolic, which is I-50.22. Now, we also have, there's a possibility that we have an exacerbation, which would be acute and on chronic. So under chronic, we come down to and on acute congestive. So that gives us I-50.23. So we have these two codes, I-50.22 and I-50.23 that we found. Then I want to go to hypertension to show you the default. I'm going to go to hypertension. Okay, so hypertension, hypertensive. So we see these terms in parentheses: accelerated, benign, essential, idiopathic, malignant, and systemic. Anything in parentheses in the alphabetic or in the tabular index are considered non-essential modifier. So a non-essential modifier is a term that can or cannot be included in the diagnostic statement, and it will not affect the code assignment. So accelerated hypertension is I-10. Benign hypertension is I-10. Essential hypertension is I-10. Idiopathic hypertension is I-10, and so on. And it doesn't affect the code, is still I-10, or if they just said hypertension, it's I-10. Because the words in parentheses are non-essential modifiers, they can or cannot be there. So before we leave here, I want to also look up hypertrophy, because the echo showed left ventricular hypertrophy. So now we are at hypertension, so we have to go to hypertrophy. So we have to scroll down. And right here, hypertrophy. So we have to go to, is left ventricular. So on the first gray line, we have to find ventricular. So right here, we see under hypertrophy, we come to ventricular non-essential modifier heart. It says see also. So we don't see what we're looking for because it doesn't give us a code. So we have to go to hypertrophy, cardiac. So whenever you see also or C, the term that is capitalized is always going to be your main term. Then you will see a comma. Anything that comes after the comma will be the subterm that you look for. So this instruction is telling us now to see hypertrophy, subterm, cardiac. So we're already under hypertrophy, so now we have to go back up to find the subterm cardiac. So right here, hypertrophy, hypertrophic, on the first gray line, we come down to cardiac. So cardiac, we have the non-essential modifiers, chronic and idiopathic, and we have a code, I-51.7. So we can also look up, since we're here, we can also look up hyperlipidemia. So we have to go up to we have to go to the L's. So I have to scroll up, hyperlipidemia. So right here, hyperlipidemia, and we see they have a code of E78.5. And then we also have to look up diabetes type 2. So we go to diabetes. And there's also a coding guideline, and I said diabetes type 2 because there's a coding guideline that when the type of diabetes is not documented, it is assumed that it is type 2. That is a coding guideline. So if it is not type 2, the provider has to document what type of diabetes it is for us to code it differently. So we go up to diabetes. So we're going to go to type 2 on the first gray line, and it says with neuropathy. So under type 2, we come to with. With is between the two gray lines. Then under with, we come down to neuropathy on the second gray line. And we see E11.40. So now we found the codes. Now the next step is to go into the tabular index to verify. So now we're going to go to back to our slide, and we see these are the codes that we found. And now the slides will have, we're not going to verify hyperlipidemia and diabetes, but we are going to really drill down on this heart failure and this idiopathic, the cardiac left ventricular hypertrophy. So before we get into that, I want to talk again about the fluid overload, because the person was admitted with fluid overload secondary to chronic systolic heart failure. So fluid overload will not be coded in this instance because of, this is from a coding clinic. And you can access the coding clinic through a 3M encoder. And if you're working in inpatient CDI, you definitely have access to 3M. So you would just go into 3M and go to the coding clinic section, and I just typed in heart failure, and this coding clinic comes from ICD-9, fourth quarter, 2002, and it's page 49 to 52. So this is the latest for this condition. So right here it says systolic heart failure occurs when the ability of the heart to contract decreases. The heart is unable to pump out adequate amounts of blood during contraction systole. Blood coming from lungs into the heart may back up and cause fluid leakage into the lungs, causing pulmonary congestion. Treatment consists of ACE inhibitors, digoxin, diuretics, and beta blockers. So we come right here. Heart failure. Heart failure occurs when the heart is unable to pump sufficient blood throughout the body. The term congestive heart failure is often mistakenly used interchangeably with heart failure. Congestion, pulmonary or systemic fluid buildup is one feature of heart failure, but does not occur in all patients. So common symptoms of heart failure are edema, fatigue, and dyspnea at rest or during exercise. So because it is one feature of heart failure, it is not going to be included because that is considered inherent. And I read this about systolic because this patient has systolic heart failure. So now we're going into the ICD-10 tabular index. So this is I-10, because I-10 is a code category by itself, because a code category, again, is the first three characters in front of the decimal point. So this says essential primary hypertension, and it has all of the, so it has all of the inclusion terms that we saw in the alphabetic index. But we're going to turn our attention to I-51.7, which was the left ventricular hypertrophy. So it is classified as cardiomegaly. These terms under here are considered inclusion terms. So these are terms that can be used, again, to include or be indicative of cardiomegaly. And even though left ventricular hypertrophy is not listed under here, that's what ventricular dilatation is. So whenever you are verifying the code, this is the first step in verifying. You go to the tabular to verify the code that the alphabetic index told you. Once you do that, the next step is crucial. The next step requires you to go to the top of the code category. Once again, it is the first three characters before the decimal. So right here, our code category for I-51.7 is I-51. And it says it's listed as complications and ill-defined descriptions of heart disease. Excludes one. Excludes one is a coding convention, which means that cannot be coded together. There's an excludes two, which means can be coded together. So our excludes one says any condition in I-51.4 through I-51.9 due to hypertension, and it says I-11 dot dash. So what that means is if we have I-10 and I-51.7, and there's nothing that says that the I-51.7 has another cause other than hypertension, we can assume that the cardiomegaly is caused by the hypertension, and we cannot use I-10 and I-51.7. We have to use the code from code category I-11 dot dash. So very quickly, how you find that is we're going to go back to the book. And we're going to go back to hypertension. And we're going to go right here, hypertension, hypertensive with, because you work from the outside in, with heart failure. And non-essential modifier congestive, we have I-11.0. So now we'll go back to the presentation. we have heart failure. So we have, because we also verify the I-50.22 and I-50.23 for the chronic systolic heart failure and possibly acute on chronic systolic heart failure. So we have to go to the top of the code category. So when we go to the top of the code category, it says code first. That is a coding convention. So we have to code first. It says code first, heart failure due to hypertension. So we've already looked up I11.0 in the alphabetic index, and it showed us, it gave us the code I11.0. This is just further proof telling us how we have to sequence. So this is going to be our principal diagnosis or our PDX for inpatient. So when we go back, these are our final codes. So we have I11.0 as our principal diagnosis, and that's going to be important because that is going to determine what our DRG is, or our diagnostic related group DRG is for this admission. So secondarily, we're going to have to list either the chronic systolic heart failure or the acute on chronic. So the reason why I included both of them is because we have to send a query on this case, because we cannot change the documentation. We need a provider to clarify, because this person, they listed this person as having chronic systolic heart failure, but the medical record is showing that they have a little more acuity than just chronic systolic heart failure. And we have our indicators to help us. But we need to write to the doctor in the form of a query and ask them to, it would be a heart failure specificity query. So we need them to look at this case again with the information we provide, and we're asking them if we're going to ask them if they can provide a more acute diagnosis. And they may come back and say, well, no, I still think that this person has chronic systolic heart failure. Or they may say, okay, well, this really does meet the level of an acute exacerbation or an acute episode. So yes, I'm going to agree that this is acute on chronic. So that would be a query. So
Could I add something?
yes, jump in.
So, first of all, beautiful presentation. I know we're getting to the end of the presentation, but we're not quite there yet. But I wanted to just add, can you see, just based on this presentation, and this is to all the viewers, why you have to know your stuff? There's a lot of nurses, about 75% or so, that make up CDI professionals. And only about 60% of them actually hold any kind of certification. Okay, and if you're thinking about coding certification, you can just forget about that. I'm talking about even CDI certifications, right? And so, for the most part, you could just only imagine how many nurses want to get into CDI, should get into CDI, or currently working in CDI, and think they can skip out on knowing the codes. You can't skip out on knowing the codes. So please resume. I just wanted to emphasize that, because that's really the reason why, yes, there's encoders, and there are tons of videos out there, where people are doing demonstrations just like this. I would say not to trust them. I would say learn how to use the coding manual and enroll in the coding nurses course, where you are able to learn from someone with a wealth of knowledge and experience. And at the opportunity, when the opportunities present themselves for you to learn from the coders that you work with, learn from those coders. And that's to all the nurses who are currently working in CDI or working in any kind of capacity where they're working alongside coders. Maybe the title doesn't say CDI, but they're expecting you to know and understand coding. Partner up with your coders and see if you can learn how to use that coding manual, understanding the coding guidelines and rules, so that you can be really impactful in your role. Please resume. Sorry, just had to add that piece.
No, I'm glad you did. And also, the reason why knowing how to use the book is so important is because now everybody thinks, oh well, I can just use the encoder. But how you use the encoder is you have to put in the right term, because from your first term, it creates a pathway. And if you go down the wrong pathway, you're going to get to the wrong code. But if you are visually looking at a book like we just walked through, you can see, oh, well, no, I need to be at this level, or I have to start here, then I have to work in, then I look at the choices. Oh, well, this is because when you walk through the encoder, you don't have choices all the time. And based on the path you pick, you won't even see the choice that you need sometimes. It takes time to know what to put in. But if you know how to use the coding book, you can open that book, find it, and then you can just type it. When I first started in CDI, I only used the encoder to actually input my codes. I did not use the encoder to look up anything. It's just, I just started, I'm like, well, let me just, use it. So I started and I really saw how sometimes if you go down the wrong path, you're going to get the wrong code. I use my book every day, every single day. So, um, so now getting back to our scenario, I want to talk about what a DRG is. So for this scenario, we're going to focus on MS-DRGs. And MS-DRGs are one type of DRG that they use in inpatient. Another one is called APR-DRG. So very briefly, MS-DRGs are medical severity DRGs, and they are used for Medicare patients. And as we know, Medicare patients are either 65 years of age or older or disabled. And APR DRGs are used basically for everyone else. So MS-DRGs are determined by the principal diagnosis, PDX, and or sometimes a major surgical procedure if performed. MS-DRGs are assigned a number called a relative weight. The weight is used in an equation to determine reimbursement by Medicare for the facility. That's a misspelling. So MS-DRGs can be increased by certain secondary diagnoses called major complications or comorbidities, MCCs, or chronic complications or comorbidities, CCs. So I want to go back to our slide where we were looking at the heart failure. Because if we see chronic systolic heart failure is a CC, which is a chronic condition or comorbidity. Then we have acute on chronic systolic congestive heart failure, which is an MCC. This is why knowing how to use this book is so important, because it will it'll pull everything together that you need. And it's a visual right here. So we see that based on the definition of an of what an MS-DRG is, we see that acute on chronic systolic heart failure is more of an impact than chronic systolic congestive heart failure, because chronic is a CC and acute on chronic is an MCC. So now we see, so the higher the DRG weight, the higher the reimbursement is to the facility from Medicare. So now we see, going back to, we have to send a query. And this is, in this case, a query needs to be issued, and most queries are initiated by the CDI specialist inpatient because there is clinical support for a more severe acuity level for the chronic systolic congestive heart failure. And here are the clinical indicators to support a higher acuity level. We have IV Lasix administered during the admission. We have daily weights. We have strict I&Os. We have pleural effusion on initial X-ray resolved on second image. And then we also have shortness of breath resolved following diuresis. So so the next two slides are going to be what the encoder will show you when you put in these conditions. The first slide I have to say is there was a mistake. This is the student version through AHIMA, because we saw in the alphabetic index that chronic systolic congestive heart failure is a CC. But for some reason, this encoder did not pick it up as a CC, and that is the current version 41. Because we see right here, it says heart failure and shock without CC or MCC, which is not true. So it should be 292, not 293. But we see for 293, we see what this is called the weight, and this is what would be the projected Medicare reimbursement, but that's not accurate because it goes into a formula based on geography and a few other variables. So it would be more money. But the one for the MCC is correct. So we see, once again, this is called the principal. We see that I-11.0 is identified as the principal because in any inpatient encounter, you have to have a principal procedure because that is how the DRG is calculated, or principal procedure if a major procedure is performed. So we see here acute on chronic systolic congestive heart failure is identified as an MCC, and we see that DRG 291 is heart failure and shock with MCC, and the MCC is the acute on chronic systolic congestive heart failure. So I corrected it. I corrected the weight for it because it's not 293, it's 292. So we see for MS-DRG 292, the weight is 0.8565, and for MS-DRG 291 with the MCC, we see it is 1.2839. So let's just say you multiplied that by, let's just say $3,000. If you multiply this number by 3,000 and this number by 3,000, you can see that this number is going to be larger. And the difference is what the hospital would have lost if let's just say the provider came back and said, yes, I do, I can specify this as acute on chronic. By CDI sending a query, they have potentially increased the revenue for that admission. And it's not, it's within your realm, and you have clinical support to back you and why you even sent a query in the beginning. It's not like, the person just received, PO Lasix and they sent them home, the next day. They had extensive workup to show that this person did have, was retaining fluid, and they had to use the IV Lasix to flush that excess fluid out, and they had to monitor them while doing it. So a query issued on this case resulting in a change of acuity of CHF will result in a financial increase for the hospital. So in conclusion, we learned how to utilize coding conventions and guidelines to make proper code assignments, and we learned how to correctly code diagnoses in code category I-11. And these are the resources, the references that I used for this presentation. And I thank you. And if you have any information on how to sign up for my course, just go to www.thecodingnurse.com and just send me an inquiry, or just look through the menu of services. And if you have a question, send me an inquiry, then we'll take it from there. And I thank you, Raquel, for working with me and allowing me to present this to your followers. Have a great day. Anything you want to add?
Thank you. Well, I'll say this, it is always a pleasure to have your contribution in this process. When I started my platform, I really started my platform because I was really concerned that there were nurses similar to me who really didn't know what they wanted to do with their nursing career. I never really wanted to work in a hospital. I understood the importance of the work that was happening in hospitals and nursing homes and institutions like that. But I've always kind of been drawn more to that care coordination. And I tell the story all the time. I was working for a practice, or working for a system rather, where we were working outpatient. And that's how I actually met the coding nurse. And we were working in an outpatient setting. We were working in a PACE program. And so for the most part, I started to see that relationship between understanding how to read a medical record for other reasons other than or beyond care coordination. And so for me, learning about ICD-10 codes, learning about revenue cycle, learning about the role of a clinical documentation integrity nurse, or just the certifications and risk adjustment certifications and risk adjustment as a methodology. I mean, all of this was just so eye-opening. anytime I'm engaging with nurses that I'm just, even if I'm just giving this a quick summary, they'll see my credentials and say, what are those credentials all about? Similar to how I ask the coding nurse when I see his credentials, what are those credentials all about? Because I see the nursing credential, but I'm like, okay, what's going on with the other stuff?
Right.
You know, how does nurses get in, get into that kind of work? And what I realize is that the more you go into this body of knowledge, is the more motivated you are to putting those pieces together. And so you literally, your mind is so transformed, it drives you into leadership roles because you see all of the missed opportunities, and you see it not just only in the documentation, but you also see the behaviors, the attitudes, the processes, the procedures, everything that feeds into either halting high quality documentation or promoting it. One of the things is having providers that get it, having medical directors that understand this, and so when you have people who get into understanding health information management and understanding this world and the lingo that comes with this body of knowledge, you have a more informed, a better connected healthcare system. You have people understanding how we can all work together with a shared goal. And so again, I'm so happy that you have taken the time to do this presentation, because this is the kind of stuff that the coding nurse does with ease. As you can see, this is just, he could do this in his sleep,
Right.
but he is taking out his time to extend himself to my audience. And I'm hoping that providers, nurses who, like me, didn't really know what they wanted to do in nursing, learn about health information management. It is transformative. It is a golden ticket to leadership. Not I hate to sound like this, but I earned a master's degree, and it was after earning my master's degree that I actually learned about health information management. If I could do it over, I would have just learned about health information management, because the education is built in within health information management. Most health information management professionals, they know that they have to take on the responsibility of being an educator. It is a part of their role, and there's so many other benefits that come from knowing and understanding health information management, and again, more specifically, clinical documentation integrity, risk adjustment, especially if you're working in outpatient, and even as just the public understanding this, when you get bills that come to your house and you don't really don't understand, well, how is it that I got charged for this? A lot of this comes down to what the providers wrote, but they failed to write in the documentation. And again, talking about that medical necessity, the coded nurse mentioned that in his presentation. Those are the kind of things and concepts that I think that nurses and providers really need to understand, so that we can better, you don't have to explain it in elaborate terms when you're working with non-clinical folks, or if you're working with patients who want to understand it. But if you understand this, it helps shape that conversation. It helps motivate you to connect with other people within the healthcare system in a different way, in a more purposeful way. And it also helps you to understand, where am I going to get the biggest bang for my buck as a healthcare professional? Is it going to be on the side at the bed where I'm providing care and somebody's constantly dictating to me what I should be doing? You got all of these people coming up with all these ideas about how long you should be in the patient's room and how many patients you're supposed to see during a day. And, or do I want to be on the side where I have this information and I can use it to motivate change? Because if you are not in a leadership role to actually be the decision maker, you could have influence in changes by having access to this information. So again, I thank you for your time. I'm not going to go any further in my elaboration. The coding nurses contact information will be in the description of this video, his website, as he shared earlier, and also other places where you can reach out to the coding nurse. I know on your website you do have the the email address listed on the contact page, but you also have a contact section that an inquiry directly on the website can be made. Is that correct?
Yes, ma'am.
Yes. So any closing remarks?
No, I mean, you and I have talked exhaustively behind the scenes about how transformative medical coding is and how just HIM in general, because it honestly has changed my life, literally. I mean, I cannot tell you how many ways me combining my clinical knowledge as a nurse with medical coding has created opportunity after opportunity after opportunity, and it continues to do so. And I know there are plenty of nurses like us who want to do something different, but not really sure how. This is how.